Hello, my name is Rachel Ashe, and today I will be performing my head-to-toe assessment. Today's date is January 24th, 2025, and this is my patient, Tyler. First, I'm going to start off by scanning the room. Where's my stuff? My stuff. The floor. The ceiling. Alright, so to begin our assessment, I will be assessing the patient's head, face, posterior chest, anterior chest, and abdomen, assessing for skin color, texture, temperature, turgor, edema, moisture, lesions, masses, and nevi. I will start by assessing the patient's head, noticing that it is regular shape, size, and in the midline position. I will then go in to assess the patient's scalp, looking at the hair texture, color, distribution, looking for any masses, lesions, infestations, depressions. And then I will go in to assess the patient's temporal arteries, noting any tenderness. He has none. And then I'll assess the patient's lymph nodes, starting with the preauricular, postauricular, occipital, tonsillar, submandibular, submental, anterior cervical, posterior cervical, and subclavicular. I will then assess the patient's jaw for TMJ, noticing any subluxation, crepitus, or tenderness. I will then assess the patient's cranial nerve 5 by having the patient clench their jaw and assessing the masseter muscle, which is intact. I will then assess cranial nerve 5 sensory function by having the patient close their eyes and tell me where you feel the light touch at.
Nose, cheek, chin, forehead.
Good. I will then assess the patient's cranial nerve 7 by having, which is for face symmetry, by having them smile, frown, pucker your lips, blow your cheeks out, raise your eyebrows. Good. I will then assess the patient's ears by assessing the pinna and the tragus, looking for any masses or tenderness, anything different. And then I will assess the patient's inner ear, looking at the patient's tympanic membrane and inner ear canal. I will then assess the patient's cranial nerve 8 by performing a whisper test. So cover this ear with one hand. I'm going to whisper something to you and repeat it back to me.
1, 2, 3.
Good. Now do it with the other hand.
1, 2, 3.
Good. And then we'll do the Weber test for lateralization. So tell me when you hear it on both sides.
Yeah.
Good. And then tell me when you hear it stop ringing. We're going to perform the Rhine test, and tell me when you hear it stop ringing.
Okay.
And
Okay.
good.
Okay.
Good. So that shows that air conduction is greater than bone conduction. We will then go on to assess the patient's eyes, starting by inspecting the eyelashes, eyebrows, and any palpebral fissures. We will then inspect the patient's conjunctiva and sclera, looking at the color, any lesions, or discharge. We will then assess the patient's cranial nerve 2, and in order to do this, I will have the patient read the letters from the chart that I don't have. Hold please. Okay. Cover up your left eye and tell me which thing. Whoop. Hold on. Tell me the lowest line you can read.
D-E-F-F-O-T-E-C.
You can do it with the other eye.
T-E-L-O-F-2-B.
Good. Okay, so you have 20/20 vision. I will then assess the patient's cranial nerve 4 for pupillary constriction to light. So normally we do this with the lights dim, but for time's sake, I'm not going to dim the lights. So look straight ahead. Good. Good. I will then assess for convergence and accommodation. So stay right at the pin light and follow it all the way in and follow it all the way back out. Good. And then I'll assess the patient's cranial nerve 3, 4, and 6 by looking at conjugate gauge to extraocular movements. So look at my finger and follow it with just your eyes. Good. Good. All right. And then I will use an ophthalmoscope to assess the patient's inner eye and for red reflex. Good. All right. Moving on to the patient's nose, we will be assessing for symmetry and straightness, and then we will assess cranial nerve 1 by having the patient close their eyes and tell me what they smell. Do you smell anything? Okay. And then we will assess patient's nasal patency by having you close one nostril with one finger. Breathe in and out. Good. And do it with the other nostril. Breathe in and out. Good. And then we will assess the patient's frontal sinuses and maxillary sinuses for tenderness. He has none. Good. We will then assess the patient's oral mucosa, looking at the patient's mouth, tongue, teeth, lips, under the tongue, salivary ducts, hard palate, soft palate, posterior pharynx, tonsils, and oral mucosa. So open your mouth. Good. And then next we're going to assess cranial nerve 9 and 10. And in order to do this, you're going to open your mouth and say "ah," and we're going to see if the uvula rises and the soft palate rises with phonation, meaning it's intact. Good. And then for assessment of cranial nerve 12, the patient will stick his tongue out and move it side to side. Good, without fasciculations. We will then move on to assess the patient's neck. So we will check the trachea, make sure it's midline. Good. And we will assess the patient's, check it this way, thyroid gland. Good. We will palpate the patient's carotid arteries. Good. And then we will listen for a bruit in either carotid artery. Using the bell of our stethoscope, the patient will take a deep breath in and hold it. Good. Breathe. And then take another deep breath in and hold it. Good. No worries. Auscultated. We will then assess the, can time turn sideways. Assess the patient's posterior chest. We will start by looking for symmetry, any deformities, none are noted. We'll then palpate for symmetric chest rise and fall. So take a big deep breath in. Good. We will then assess for tactile firmness. So I'm gonna, every time I move my hands, say 99. Say it now.
99. 99. 99. 99.
Good. Oh, then we're going to percuss over the lung fields. Good. And then I'm going to auscultate his posterior lung fields. Getting the bases and the lateral fields. Good. And then we'll listen for egophony. So every time I move the stethoscope, say EE. And then bronchophony, every time I move my stethoscope, say 99. Good. And And then we're going to whisper paralytically, so every time I move, just whisper 1, 2, 3. Good. Alright. We will then have the patient turn straight and assess his anterior chest. So, once again, we're going to inspect for any deformities and for symmetry. We will also have the patient take a deep breath in and palpate for chest symmetry. Good. And then we will listen to the lung fields again. Getting the lateral fields as well. Good. We will then assess the patient's 5 cardiac points, starting with aortic, pulmonic, herbs, tricuspid, and mitral. I'm going to use the diaphragm and the bell of my stethoscope. So starting with the diaphragm, we will do aortic, pulmonic, herbs point, tricuspid, and mitral. And then the bell of our stethoscope, aortic, pulmonic, herbs point, tricuspid, mitral. Good. Then I will find the point of maximal impulse and palpate it, so it'll be on the left side, mid-clavicular line, 5th intercostal space, about right there. And then I'll use my stethoscope and I will auscultate the apical pulse for 1 minute, reading the patient's rate and rhythm. For time's sake, I'm not going to do the whole minute, but he's in normal sinus rhythm at a regular rate. Alright, I'll then have the patient lay on his back. Either side, it doesn't matter. Good. So once the patient is laying down, I will assess for any jugular vein distension, jugular pulsations, any heaves or lifts. None are noted. And I will palpate the 5 cardiac points for any thrills, starting with the aortic, pulmonic, herbs point, tricuspid, and mitral. And then I will listen to him again while he is laying flat, using the bell and diaphragm of my stethoscope. Aortic, pulmonic, herbs point, tricuspid, mitral. And then the bell, aortic, pulmonic, herbs point, tricuspid, mitral. Good. I will then move to assess the patient's abdomen. So we'll start by looking for symmetry, any funky curvatures, anything off, and then we will first start by auscultation, listening for bruits in any of the arteries in the stomach. So using the bell of our stethoscope, we'll start with the aorta, then the renal arteries, then the iliac arteries, and then the femoral arteries. Good. And then we will use the diaphragm or stethoscope to listen to the 4 quadrants for vowel tones in each one. Okay. We will then percuss all 4 quadrants of the abdomen for dullness, tympany, and flatness. And then we will palpate all 4 quadrants of the abdomen for any masses or tenderness. Sorry. Alright, and then we will palpate the right side for the liver, and then the left side for the spleen. Okay, good. And then we'll have the patient sit back up, kind of turn sideways like you were. And we will assess for costovertebral angle tenderness. So I'll turn my head to one side and hit it, and then turn my hand to the other side and hit it. Good. Okay, you can turn straight. Good. Alright, now we will move on to the musculoskeletal assessment of the upper extremities. So we will be assessing the Hands, wrists, elbows, and shoulders, looking for any redness, swelling, tenderness, masses, nodules, crepitus. And we will start with capillary refill of both hands. So turn your hands over. Cap refill is less than 3, and then we will assess the radial pulse on both sides. Good. We will then move into range of motion. So we're going to start with your fingers. Hold your hands out and flex, extend, hyperextend, abduct, fingers out, adduct, fingers in, and then thumb opposition. Good. And then we'll move to the wrists. So make fist, flex, extend, hyperextend, ulnar deviation, turn them out, radial deviation, and then rotation. Good. And then we're going to do your elbows. So hold your arms out. You're going to flex, extend, hyperextend. Good. And then we're going to do your shoulders. So you're going to flex, all the way up, extend, hyperextend, kind of as far as you can backwards. Good. And then you're going to internal rotate, external rotate, adduction, abduction, and then circumduction. Good. And then we're going to assess for strength. So you're going to grip both of my fingers with your hands. Good. And then we're going to do your biceps and triceps strength. So hold your arms like this. For biceps, I want you to pull against my hands. Good. For triceps, push against. Good. And then we're going to assess shoulder strength. So hold your arms like this. Push down against my hands. Good. And then pull up against my hands. Good. And then we're going to assess cranial nerve 11 by, I'm going to press down on the patient's shoulder and he's going to shrug up against my hands. Good. We'll then move into assessing cerebral coordination. So you're going to start with the hand flip-flop like this. Good. And then you're going to do serial finger opposition. So do your fingers like this on both hands as fast as you can. Good. And then we're going to do finger to finger. So touch your nose and then touch my finger. And then one more time. Good. And then do it with the other hand. Good. Good. Alright. And then we will do, I will assess the patient's upper and lower extremities for edema, and make sure the skin's intact, warm, and normal color. Alright. So, no edema, everything's intact, minus his finger, but he's a blue collar worker, he can't help it. We will then move to assess for light sensation touch. So close your eyes and tell me where I'm touching you at.
Yeah, what?
Which arm?
Right arm. Left arm. Right.
Good. Alright, and then we will move into vibratory sensations. So I am going to hit this, and whenever you feel the vibration, let me know. We're going to start with your proximal ulnar deviation, and then we'll do your medial malleolus on both sides. So, okay.
Okay.
Then medial malleolus.
Okay. Okay.
Good. All right, and we will then move into assess the patient's deep tendon reflexes. So we'll start with the brachioradialis, and then we'll do the biceps. Good. And then we'll do the tricep. Kind of let your arm hang on both sides. Let it hang. Good. And then we'll do the patella, which your legs aren't hanging, so it's kind of difficult, but it's okay. And then we'll do the Achilles. And then we'll do the Babinski. Good. Alright. We will then move to assess the patient's lower extremity musculoskeletal function. So this will be the patient's feet, knees, or toes, ankles, knees, and hips. We're looking for any tenderness, swelling, nodules, crepitus, redness. So we're going to start with checking the patient's toes for capillary refill. Good. And then we're going to assess the patient's dorsalis pedis pulses and then post-tibial pulses. Good. And then we're going to do range of motion of the patient's toes. So I'm going to have you flex your toes in, extend, hyperextend, abduct your toes, and then adduct your toes in. Good. And then we're going to do ankles. So you're going to dorsiflex up, plantar flex down, inversion, turn it in, then eversion, turn it out, and then rotation all the way around. Good. And then we're going to assess the patient's strength. So we're going to start with strengths of the ankle. So I'm going to have you dorsiflex, hold your legs out, and then dorsiflex up against my hand. Good. And then push plantar flex down against my hand. Good. And then we're going to assess the strength of the patient's knees. So I'm going to have you pull in against my hand. Good. And then push out against my hand. Good. And then we're going to do the patient's hips. So I'm going to have you push out against my hands. Good. And then pull in against my hands. Good. Then I'm going to have the patient stand. And once he stands, I'm going to assess the patient's range of motion of his hips. So we're going to flex our hip, extend our hip. Sorry, you can move forward. Hyperextend your hip. It's okay. And then you're gonna internally rotate, externally rotate, and then you're gonna abduct, then adduct, and then rotate. There you go. All right, and then we're gonna assess the range of motion of the patient's knees. So you're gonna flex, extend, hyperextend. Good. All right, and then we're gonna assess the patient's back. So I'm gonna have you turn sideways, bend kind of like laterally to the ground. That'll do. So I'm checking for any curvatures, any disalignment, mainly checking for scoliosis. His is aligned. No scoliosis is noted. I'm gonna have you stand back up, and we're gonna do range of motion of your lumbar spine. So you're gonna flex, and then extend, then hyperextend, and then laterally rotate both sides, and then all the way rotate. There you go. Good. And then I'm going to do the patient's cervical spine. So I'm going to have you flex, extend, hyperextend, lateral flexion. Good. And then rotation. Move your head all the way around. There you go. All right. And then we're going to have the patient turn forward, and we're going to perform the Romberg test. So hold your arms out in front of you and close your eyes. Good. And then we're going to, you can put your arms down. Then you're going to just walk regularly towards the camera. And then I want you to tandem walk back. So heel to toe back. No, you can do forward, like turn around and walk forward. But heel to toe. Good. And then turn. And then hop on one foot. Do it with the other foot. Good. And that will conclude our head to toe assessment. Thank you.